So we now have the Dr. Vivek Nangia, the Director and Head of Pulmonology, Max Super Specialty Hospital, New Delhi. We'll be talking on approach and management for undiagnosed TB in clinical practice. It's quite important to all internists, as Dr. Gupta said. We do have a lot of problems and still keep on coming. He is a Chief Pulmonologist, Cluster Max Hospital, Principal Director and Head Institute of Respiratory Critical Care in Sleep Medicine, and Vice President of IAB. 30 minutes for you.
Good evening, everybody. At the outset, I'd like to thank Dr. Pathak for inviting me here this evening. It's really an honor. In fact, last year also he had invited me, but I couldn't make it. This year, I have postponed my summer vacation only to be here with you all. So, which we start from tomorrow, which was actually to start last week, but we postponed it and planned it in such a manner that it starts tomorrow now. So anyway, I think there's some connection loose here. But let me start with this. So, approach to undiagnosed tuberculosis. I was talking about tuberculosis earlier also in the evening. Tuberculosis continues to be a rampant infection in our part of the world, especially if you look at the WHO statistics for the global statistics. There are more than 10 million people suffering with TB, about 1.3 million deaths every year. This is 23 report. In 2022, there were about 1.3 million deaths. There's something wrong with the connection. Yes, हटाओ पहले नीचे से इसको. So this is the second leading cause of death from a single infectious agent after COVID. Imagine the number of deaths that we've seen with COVID, and this is the second leading cause of death around the world because of an infectious agent. More than that, because of HIV. HIV is so considered to be like a death warrant the moment anybody is diagnosed with HIV. On the contrary, it is TB which is resulting in more deaths than HIV does. And India continues to have the largest burden, contributing about 27% of the global incidence of tuberculosis comes from India. So more than 1/4 comes from India. And of course, the MDR TB is becoming more and more common. Globally, there were like 4 lakh cases in 2022. And in India, there are about 64,000 cases of MDR TB which have been notified. Now with Nikshay coming up, the notification rates have gone up significantly in our country also. There are about 172 cases per lakh of population and about 24.2 lakh cases, which is a 13% rise from 2021 to 22. So when do you really suspect tuberculosis is the first question that I'd want to ask you. Classically, anybody with a cough more than 2 weeks, fever more than 2 weeks, especially if it is low grade, evening rise, associated with night sweats, that is what classically would be the fever pattern in a patient with tuberculosis. If they have hemoptysis, if they have a non-resolving pneumonia despite a course of antibiotics, and any abnormality in chest X-ray could qualify for a suspicion of tuberculosis. And especially so in patients who have been in contact with a microbiologically positive patient, like a one of the members of the family who are positive for TB. People living with HIV, they are more prone to developing tuberculosis. Diabetics, malnourished people, cancer patients, patients on immunosuppressive therapies, especially nowadays with so much of all these disease-modifying agents being used like MMF, rituximab, tuberculosis is becoming very common. In fact, before starting rituximab therapy in any of your patients, you must evaluate them even for a latent TB. And if positive, then you may want to consider giving them an INH prophylaxis or an LTBI treatment. So let me start with these cases. Now, first case is of a 52-year-old male, chronic smoker, cough, phlegm, low-grade fever for 2 months, loss of weight for 3 kgs in 3 months, has creps in the right infraclavicular area, ESR is 118, MAN2 positive, HIV negative, sputum AB smear negative, and this is what the X-ray is. So what would you do? Man2 positive, HIV negative, X-ray showing typical pattern in the right upper lobe. Would you want to start treatment or not?
Yes.
You would want to start treatment. CB-NAT. So basically you could give these patients a trial of antibiotic initially, 7 to 10 days, but please be careful that you use something like an amoxicillin, like a cefuroxime, and not a fluoroquinolone or a linezolid. Both these drugs are very good antitubercular agents. We reserve them for our MDR TB patients and do not use them routinely in any of our patients. These drugs are completely banned from our unit, and we have never used a fluoroquinolone for our OPD patient or even in an ICU, unless you have proven beyond doubt that this is not TB. If you use any of these drugs, you're only delaying the diagnosis of tuberculosis by 2 to 3 weeks, because that is the time it takes for the bacteria to start showing up again. And then we need to remember that there is no role of all these inaccurate tests of IgM, IgG, IgA that we get done for all our TB patients. And even the IGRA has not been validated in India yet. So it is not recommended to be used for the purpose of diagnosis of tuberculosis. Now, as far as the features of tuberculosis on a chest X-ray are concerned, they can be wide and varied, starting with focal infiltration. It could be unilateral, bilateral. It could be airspace opacities with the nodular opacities, tree in bud appearance. It could be anything really. There could be cavitation, there could be enlargement of the nodes, small fibronodular opacities which are called miliary mottling on a chest X-ray, which you may need to confirm on a CT scan subsequently, or pleural effusion. The variety can be large. I mean, the options of on a radiological picture for a tuberculosis patient can be similar to anything else also, like a viral infection, like fungal infection, pneumonia, malignancies. So there's so many overlapping features. So you may get a CT scan done in these patients. CT scan also showed this airspace nodular opacities. Then what? Would you start the treatment or not start the treatment? You would still want to do a microbiological diagnosis for these patients. Why? Because it is important to know whether this is one, tuberculosis finally or not, two, whether this is drug resistant TB or not. Even in the drug resistant, is it monodrug resistant, polydrug resistant, MDR TB, XDR TB? Unless you know that, you should not be starting the treatment, at least making an attempt to reach somewhere near there, even if you're not able to reach a final diagnosis as far as the microbiology is concerned. So of course, simplest would be to send a sputum sample. 2 sputum samples sent together can, within a gap of 2 hours can be sent. You could ask the patient to nebulize with a hypertonic saline and then collect the sputum sample and send it. Or a bronchoscopy is a very, very simple option. It just takes about 2 minutes going in, coming out under local anesthesia without sedation, and you have a sample ready to send, which has come from the depths of the airways. This is one study which was recently published from Korea, nationwide prospective cohort study, where they had some 5,000 patients, out of which so many were excluded from the study. 319 finally underwent bronchoscopy, and out of these 319, and these are all smear negative patients, AIB smear negative on the sputum, 50% of them could be diagnosed based on the bronchoscopic results. Of course, I'm not saying that every patient should be subjected to a bronchoscopy. Bronchoscopy should be reserved for patients who have an unsuccessful attempt to obtain the expectorated sample, negative sputum studies repeatedly, and yet the index of suspicion for TB is very high. Potential alternative diagnosis exists in your mind. Urgent diagnostic information is needed if the patient is critically ill. Then you wouldn't want to wait for the sputum report to be coming, but you would be sending the sample immediately. Then what is also important is once you've done the bronchoscopy, you've actually unsettled the lungs inside, patient coughs, patients sometimes bring out more phlegm from inside than you expected. So you can even collect the post-bronchoscopy sputum sample and send that too. And then of course, what we've started doing now is also sending the tissue biopsies. You do a transbronchial biopsy, send one for histopathology and one for culture. Culture, AIB smear, gene expert, all three are sent together. So the costs go up significantly when you do procedures like this, primarily not because of the procedures, but because of the lab investigations. But they are essential. They are essential to reach a definite diagnosis. How else would you reach a microbiologically confirmed diagnosis, which is now required for most of our patients, if not all? So a transbronchial biopsy would classically show you the caseous necrosis, which is classical of tuberculosis. And when you send the microbiological samples, you send it for AAB smear, you send it for cultures. Cultures also, we believe in MJIT now. We moved away from LJ media. Then you put them up. Once the culture is positive, you get a sensitivity done. Sensitivity will tell you which drugs are best suited for this patient, whether this is rifampicin resistance or not. Other than that, you can even do the gene expert and the molecular studies, which I'll just describe. So as far as AAB smear is concerned, it continues to be a simple, inexpensive tool with a high specificity. Results are available quickly and correlates very well with the infectivity of the patient also. But the major drawback is that it requires at least 10,000 bacilli to be present in that sputum sample to be detected and reported as sputum positive. But the better thing is that as far as radiology is concerned, it's more specific and has less inter-observer variability. That means if two people are seeing the smear, the chances, and two people are reporting the X-ray, the chances that the diagnosis will match are higher when it comes to sputum than when it comes to a X-ray. Then we have rapid diagnostic tools that are available to us now. Gene Expert is one of them that we use very rampantly, and it requires all of 10 bacteria. The Gene Expert Ultra, which is now available for the last 1 year, requires only 10 bacteria to be present in the sample to be reported as positive. It has excellent positive predictive value, and the results are obtained from the unprocessed sputum. It doesn't require any processing to be done. This is a US FDA as well as the WHO approved modality of investigation. After this, so what is the advantage with Gene Expert? Gene Expert gives you one, it is positive. Second, it also gives you whether it is rifampicin sensitive or rifampicin resistant. Whether it is rifampicin sensitive or resistance, that should not hold you back. Once your Gene Expert is positive, you must get an XDR Gene Expert also done. First Gene Expert only gives you sensitivity against rifampicin. The XDR Gene Expert gives you the sensitivity pattern against INH, ethionamide, fluoroquinolones, aminoglycosides. So all four of the drugs, so you know exactly whether the patient has any other resistance or not. This is also recommended by WHO now, and almost like a part of our protocol now for any patient in our unit who turns out to be Gene Expert positive or smear positive, we get their XDR Gene Expert also done. The specificity is 98 to 100%, and most accurate results have been seen with INH and fluoroquinolone resistance. Apart from that, there are also line probe assays. Line probe assays are mainly done once the patient is sputum AFB culture positive. Once that is done, then they could do a Haynes line probe assay, Haynes 1, Haynes 2. And again, Haynes 1 would give you the sensitivity against rifampicin and INH, whereas Haynes 2 would give you the sensitivity against fluoroquinolones and the second line injectables. So collectively, you'll get to know about the entire spectrum, whether this is sensitive or a resistance AFB bacteria that you're dealing with. So coming back to our case 1, we had Gene Expert positive on the bronchoscopy, and we got the XDR done. XDR was also pan sensitive, so we continued with our HRZE. We'd done the transbronchial biopsy also, which showed necrotizing granulomas. The bile and tissue AB cultures were negative, but this patient did well with the treatment that was started. Now coming on to our second case, 36-year-old female with low-grade fever for 2 months, mild dry cough, CBC within normal limits, ESR of 35, MAN2 negative. What do you see on the X-ray? Anything? So just some mild right hilar enlargement here, probably bilateral hilar. So we got a CD scan done. CD scan confirmed the presence of mediastinal lymph nodes. So what next? MAN2 negative, mediastinal lymph node positive. You would think of sarcoidosis, you get the ACE levels and all done, they're all normal. So what next? You basically have to form the diagnosis. For the extrapulmonary diagnosis, you may rely on the microbiological reports. Again, you need a sample from inside, whether that is for the AFB smear, culture, gene expert, all of them. But also, you would need a tissue diagnosis. So you would want a cytology or a histopathology to be taken and then correlated with it. So EBUS is a very good modality. It just takes about 30 minutes for the procedure to be done. Could be done under mild sedation, could be done under deep anesthesia depending on the patient's requirements and the patient's cooperation levels. This is being done for nearly 15 odd years or probably longer now. And the expertise is actually growing. You can do a rapid on-site evaluation as we do in our hospital, which is called ROSE, and the diagnosis is available within minutes. Even before you end your procedure, you know what you're dealing with in some cases. The cytopathologist or your own well-trained pulmonologist can actually sit and see the slides and tell you while you're doing it. And as far as the lymph nodes are concerned, there was a discussion going on prior to this. EBUS can easily access the stations 2, 4, 7, 10, 11, 12. The EUS BFNA, as we call it now, endoscopic ultrasonography with bronchoscope FNA, which is done through the esophagus, can also access paraesophageal lymph nodes at 8, 9, 3P, and of course subcarinal can easily be accessed by that also now. And the diagnostic yield goes up till 68 to 87% and sensitivity is 45 to 95%. And for lymph nodes which are beyond the vessels, in expert hands you can even do a transvascular needle aspiration. The needle accept has to be very fine and the stroke has to be very gentle when you're puncturing the vessel, but then you need to have that expertise to be able to do this. From just needle aspiration, we've started doing transbronchial cryobiopsies also now from the mediastinal lymph nodes. This is a video of that where you can see initially a transbronchial needle aspiration is being done from the lymph node, where we are puncturing the lymph node repeatedly with the needle and taking the aspirate. After this, we take out the needle and just puncture that site again 2-3 times to widen it a bit. Once that's widened, then you put in a 1.2 mm cryo probe into the lymph node and can take a biopsy. People have also inserted the usual conventional biopsy forceps into the lymph node and taken a biopsy for a better yield. Again, it's all about the size of the tissue that matters. The amount, the quantity of sample that you're sending to the lab will be directly proportional to the better result that you will get. And as Dr. Prashant also said, what is important is to get to a diagnosis. You know, these are patients who are troubled because of their fever, because of their symptoms, and are not reaching an answer. Sometimes all you get is just some reactive lymph node. You may get some just granuloma there, but is that sufficient? That doesn't help you reach a diagnosis. There can be several granulomatous diseases that could be resulting in this kind of a lymphadenopathy and fever. Therefore, when you collect the sample, and this is not a procedure that you can repeat so often. So when you take the sample, you send it for everything possible. Cell count, cytology, your cell block, microbiology, cultures, AB smear, gene expert, everything is sent in one go itself. So this is the cryo probe which has been inserted. You can see this, the tissue is then frozen and pulled out. It just about 2 to 3 seconds is all that it needs to be frozen for, and you pull it out and you get a very good sample. So it's less invasive than mediastinoscopy and VATS lymph node biopsy. It takes you beyond the cytology or cell block and gives a much larger volume to get you a better diagnosis and of course an adequate sample. So in our case too, we had the BAL AB smear, gene expert AB culture all negative at 6 weeks also. EBUS ROSE was done and it showed only a reactive lymph node, but we did the EBUS TBNA which showed occasional granulomas and gene expert was negative, but then the AB culture turned out to be positive at 3 weeks, and on drug sensitivity it was sensitive to all. The EBUS cryobiopsy confirmed the presence of necrotizing granulomas, and TB culture was positive at 3 weeks, yes. Now coming on to my third case and the last case for the evening. Now we look at the pleural effusion, which can be again very challenging at times. 60-year-old male, diabetic, right-sided chest pain for 1 month, dry cough and shortness of breath with an absent air entry, and this is what the X-ray looked like. Had undergone a diagnostic pleural aspiration before coming to us with proteins of 4.2, sugar of 100, LDH 682, ADH 22, lympho predominant 75%, and malignant cytology was negative. So what would you do in this patient? Start ATT or not? The features are classical of TB. No, not start ATT. Then do what? Then do what? Sorry? Cell block was also negative. So what do? This is what brings you to the concept of medical thoracoscopy, a procedure which is done by the pulmonologist in the bronchoscopy suite itself with hardly any costs involved. It can even be done bedside, it can be done in the ICU, it can be done with the patient sitting up. It does not require any general anesthesia, just low, mild sedation, much cheaper than a VATS procedure for diagnostic. So I'm not comparing VATS versus medical thoracoscopy. I'm comparing medical thoracoscopy in an undiagnosed pleural effusion versus VATS in an undiagnosed pleural effusion. Otherwise, thoracoscopy and VATS have different indications altogether. So when you do this, then the chances of reaching a diagnosis become much higher. Just with a simple needle biopsy, the chances are 51%. When you do the cultures, 28% adds on, collectively 61%. When you add medical thoracoscopy to it, the chances are that 99% you will reach a diagnosis, and you combine it with the culture of pleural fluid, 100% that you will reach a microbiologically confirmed diagnosis. Why do I say that? There are certain very typical features that you get to see when you do a thoracoscopy in a patient with tuberculosis. If you see something like this, see these thin fibrinous bands, those small little nodules, loculations which are very thin, not thick. They're classical of tuberculosis. You see this and you know it is TB and nothing else. If you're able to break these adhesions, then they are tubercular. This is a classical loculation. You puncture it and the fluid comes out. You take a tissue take a sample from these adhesions and send them for culture. The chances of getting a culture positive from this fibrinous adhesion is higher than that from the pleural fluid. So we always take these tissues and send them for cultures of our patients. So this is like a spot diagnosis that there is confirmed TB. Now you only need the microbiological confirmation. So you take as much tissue as you want and send it all for cultures. And also it provides you the opportunity to break all these thin adhesions and prevent the patient from developing a fibrothorax subsequently. So Sago-like pleuritis, mealy granulomas, grayish-white blanket, and thin fibrinous adhesions are classical of tuberculosis. This is another patient. But then the quest for more and more is never ending really. You always want more sample, more tissue. That is why now we moved on to cryobiopsy from the pleural space also. Because you have to reach a diagnosis, especially in patients where there's a dilemma that it may be tubercular, it may be malignant, like this patient for instance. There was this single nodule there. So how do you ensure that you get a good sample? Of course you do take biopsies, but then you want more tissue for confirmation sometimes. So you take a cryobiopsy now. This is a conventional biopsy from that nodule. I'll try to forward this a bit. So this is the cryoprobe being inserted into it. Just put it there, attach it to the surface, freeze it, and bring the tissue out. It's just so simple. So simple. It doesn't take longer than 5 to 6 seconds and you're out of it. So in our case 3, we had a pleural tissue which was gene expert positive, rifampicin sensitive. We did the XTR gene expert which was INH resistant and also fluoroquinolone resistant. So that is the whole advantage of doing a gene expert, which gives you INH resistance as well as resistance to fluoroquinolones, aminoglycoside. So you can actually, this one report, change the entire line of treatment for this patient. Otherwise, the patient would have continued to receive HRZE and landed up in complications subsequently. The AFB culture, of course, pleural tissue confirmed necrotizing granulomas. So my friends, I would like to summarize my talk by saying that, it is no longer the era of treating a patient of presumptive tuberculosis with just ATT randomly. We must make a sincere effort with all the armamentarium that is available to us now to reach, at least make an attempt to reach a confirmatory histopathology plus a microbiological diagnosis before starting a patient on antitubercular treatment. Especially when you're dealing with extrapulmonary tuberculosis, it becomes even more imperative to get at least a histopathological sample and microbiological diagnosis before you can start them on treatment. Thank you so much for a very patient hearing, and thank you for inviting me this evening.
Is it? Yeah, thank you, sir. Nice presentation.
Thank you, sir.
I have 3 small query because we represent a still community which is extremely poor, hardly can afford anything. Now radiologists have become non-committal. If you look at the X-ray report, it's totally, they leave it to the physician for altogether different reason. How frequent you see basal lesion? Because traditionally, apical lesion, fibrosis, trachea pulling, conventional you start in tubercular. I was talking to Dr. Rajendra Prasad also. We have been taught before also, the extra pulmonary manifestation of tuberculosis always is either post-primary or progressive primary. It's not the primary complex. In that context, how frequent you see basal lesion and you did the procedure and you got the confirmation that it is a tubercular? Number 1. Number 2, somehow TB gold has become very popular among the general physician. I don't know from where it came, but everybody wants TB gold. Where does it stand today in that perspective? And last is the ADA. In spite of protein very high, you get the report, high lymphocyte count, ADA remains on the lower side. So these 3 queries for general physician who hardly have chance to get into these procedure and get the response.
Right, sir. Thank you so much, sir. Very valid questions, all 3 of them. The first was about, okay, let me start from the third question then first.
TB gold.
TB gold. TB gold is a very non-specific test. As I said, TB gold only reflects the latent tubercular infection. It does not relate with an active tubercular infection. The only situation where one would use TB gold, as far as we are concerned, would be once you've ruled out or done the entire investigative workup and not reached any confirmatory diagnosis. That is when you may consider using TB gold as your only ray of hope of reaching the diagnosis and starting the patient empirically on treatment, but not until you worked the patient up exhaustively, completely, that you are mentally satisfied, patient is mentally satisfied that yes, everything has been done, and that too after taking the patient into full confidence. Because latent TB, every 3rd individual in India has a latent TB positive. If you were to do their quantiferon gold or TB gold or a Mantoux test, it would invariably be positive. So you can't really start somebody on treatment for that. So first question was about basal involvement of patients with post-primary tuberculosis. So the teaching is that the primary tuberculosis happens in the upper lobes. Post-primary tuberculosis, which classically happens in adults, happens in the superior segments of the lower lobes. In diabetics, immunocompromised patients, you could get a lower lobe tuberculosis also. HIV patients, diabetics, those on immunosuppressive therapies, cancer patients, they could develop tuberculosis in the lower zones also. And third was about ADA, sir. ADA again is a good tool if it completely fits into that picture. You know, there is no one single report that you can rely on when you're forming a diagnosis of an effusion. You have to look at the holistic picture. The cell count, the LDH, the ADA. ADA could be high even in an empyema. A low ADA definitely merits further investigative procedures like medical thoracoscopy. But an ADA in the range of 45 to 75, with an LDH in the range of 600 to 700s, with lymphocyte predominant exudative effusion, there you are safe in diagnosing it as tuberculosis. But other than that, you have to think twice, you have to work up the patient further before reaching the diagnosis of tuberculosis.
That's the real brilliant answer for most of the questions for internist.
Thank
Any
you.
other comment from the audience?
There can be, sir, certainly. Endobronchial tuberculosis can present with sputum positive, X-ray negative. Plus also X-ray will be non-specific, you know, unless you get a CT scan done and say that radiologically there is no involvement of the parenchyma. Yet, patient could be positive and there's an endobronchial tuberculosis. We've had patients who are being treated as asthma. Young girl, doctor herself, just finished her internship, for 6 months being treated as tuberculosis, as bronchial asthma because of her wheezing. When we did her bronchoscopy, when she came to our hospital, we did her bronchoscopy because her wheeze was not settling, despite all the steroids, bronchodilators, did her bronchoscopy. There were extensive involvement of the tracheobronchial tree. She had developed a right main stem bronchial stenosis by now, an AIB smear positive, gene expert positive, rifampicin sensitive, started on ATT. She just came back. I mean, of course, she was on regular follow-up, but recently got admitted after almost a year now of her treatment. Absolutely well, no wheezing, even the bronchial dilatation has improved. We've had to do the ballooning for her to dilate the right main bronchus. And she's not one patient. We have 4 or 5 such patients with just endobronchial tuberculosis resulting in right main stem bronchial stenosis.
Dr. Prashad. How frequent you get this? You can have this micro.
So as I said, I've seen about 5 patients so far. Very few. Very small percentage, but yes, anybody with persistent wheeze, asthma not settling, should be investigated for endobronchial lesions.
What about bronchial adenoma?
Absolutely, sir. That's what I said. Bronchial adenoma, carcinoids, tumors, cancers. So anybody with a persistent wheeze which is not settling must be investigated, even if on the X-ray looks normal, even if the CT scan looks normal, because those minor bronchial stenosis may just get missed on a CT scan.
Thank you, Vivek, for really telling very nice thing. And 2 things I would like to react to your question. One was the radiologist opinion about the X-ray. You know, sir, I must tell you, when I became faculty in 80s, when I used to teach TV and radiology, I used to tell there are certain findings which favors tuberculosis. But now, after about 45, 46 years, if somebody asks me, what is the lesion in chest X-ray which favors tuberculosis, I'll say none. Any lesion, anywhere could be. That's why that I'm not defending the radiologist, but radiologist just imagine yourself. About the localized wheeze, what Dr. Ansari is my senior. When I was JR1, he was my senior resident.
Okay.
Those days was known as chief resident. I am talking of 70s again. One of the localized wheeze I saw, one of the very important, one of my professor, he came to me a fine morning कि राजेंद्र वो मेरी सांस कुछ आज सुबह से फूल रही है हल्की हल्की. तो मैंने कहा सर आपको तो कभी मैंने देखा नहीं, कभी आपको कोई हिस्ट्री अस्थमा की, मैंने सारी पूछी तो बोले नहीं ऐसा कुछ नहीं. तो मैंने कहा कि भाई ठीक है इन्वेस्टिगेट, हमने कहा एक एक्सरे तो आप करा ही लीजिए. तो ही गॉट एक्सरे डन. तो एक्सरे में एक टूथ दिख रहा था. And that was and on the examination only one finding was there was a localized
Monophonic wheeze.
Monophonic wheeze. So I said sir एक्सरे करा के तो देख लेते हैं. तो मैंने कहा इसमें दांत कैसे जा रहा है. दिख रहा, तो उन्होंने अपना मुंह खोला, उनके पास गोल्डन, बहुत सीनियर प्रोफेसर थे, गोल्ड का वो लगा था, तो बोले यार वही चला गया. So sometimes, you know what I'm trying to say, foreign body does not always tells you that it is foreign body. I can narrate you hundreds of stories, but this is one of the story what I remember. So localized wheeze is also a very important in clinical examination. You should never ignore it, try to investigate. Thank you, sir.
Ji, sure.
Sir, my question is about the granulomatous diseases. The most commonly we are getting the sarcoidosis and the tuberculosis. So most of the findings are same in the both of diseases. Only thing which I experience, sir, that if we are lucky and we get the microbiological confirmation of the tuberculosis, at that time I am 100% sure that we are dealing with tuberculosis. Otherwise, I always in a dilemma whether we are dealing with tuberculosis or sarcoidosis. So what is your, sir, your experience?
So very good question. In fact, this is a dilemma that we face very often, and just recently also we've had one such patient where despite all extensive workup, we could not find anything. And ultimately that is the time when you start telling the patient that there's so much of overlap between sarcoidosis, tuberculosis, these are the limitations of medicine, these are beyond our control also. We've sent everything possible and still not been able to reach a diagnosis. Well, yes, that happens, but not very often, rarely. And that is when the role of your IGRA, your MAN2, your ACE levels comes into play. You try and correlate. So, you put the entire picture into, you have a holistic kind of an approach, put the various things into one single puzzle and try to solve it for yourself. So there you'll have to rely more on a clinical sense and probably start them on a combination of ATT with steroids, with patient being warned about it, that how you will fare, it's difficult to say, but yes, this is one situation where you're totally at a loss.
Thank you, sir.
Sir, I have just a practical question which we come across very often in the clinical practice. So, what I learned from your talk is that the gene expert tells you only about the rifampicin resistance, but doesn't tell you about the rest of them. So, somebody who has been started on ATT by anybody, based on just the gene expert report, which was positive and did not show rifampicin resistant, and he had a 4-drug combination which he ran for 6 months or 9 months. But you're not sure whether the INH was really he was sensitive or resistant to. Now, in this kind of scenario, when you stop the ATT, because you guys do that very often, because this is in your clinical practice. So, what are the precautions you take? Is it just you go by the duration that he has finished 6 months or 9 months or whatever period you want, or you do some test as well just to make sure that he doesn't need ATT anymore?
So basically you would do a radiological follow-up also of these patients as well as sputum follow-up of these patients. Of course, the National Tuberculosis Program does not say that. They only look at the sputum reports at 1 month and 2 months, and if those are negative, then they just complete the 6 months therapy and stop that. But from when you're doing it in your private practice, then of course you ensure that radiological clearance has also happened, or at least if not clearance, then radiological stability has been achieved over 2 months. Only then you would discontinue the treatment. You may extend the treatment from 6 months to 7 months. The other thing is, because of this monodrug resistance to INH, that is the reason why now in the continuation phase we give 3 drugs, rifampicin, INH and ethambutol, that in case there is INH resistance, that would also be taken care of by the other 2 drugs.
Thank you.
Thank you, sir.
We wind up the session because we are still behind the schedule. But it's a wonderful presentation and the clinical correlation.
Thank you very much, sir. So to present Memento and Agavastram to Dr. Vivek Nangia, I would like to call Dr. S.K. Pathak, sir.